Thank you so much for joining us in this conversation today in the Moving the Mission, Part 4, hosted by the Giffords Center for Violence Intervention. We're really looking forward to our conversation today. Just so you can kind of get a sense of how this will go, we will have a panel discussion. I'll introduce them shortly. But for the purpose of this, please feel free to add questions in the chat as we're going along. We really want you to feel part of the conversation, very similar to a dialogue amongst friends and colleagues. So please add questions to the chat as we're going throughout. We'll have an opportunity to address those in the panel's discussion. If we're unable to address it there, we can definitely feel free to reach out to us. We can answer any specific questions that you may have. But we really look forward to having an interactive conversation with everyone here today. So, kind of what brings us here? As I mentioned earlier, this is part 4 in a series titled Moving the Mission, where we hosted a series of webinars coming out of our conference. And really the genesis for this was really informed by a report that our team put together titled Moving the Mission. And from the Moving the Mission report, we were able to identify tools, resources, and opportunities that came out of last year's conference to really also reflect on the state of the field, identifying themes and questions that have emerged over the course of those reflective dialogues, and really looking to see this as an opportunity to continue to build upon those conversations as we really push this work collectively forward. And so, for the purposes of our conversation today, really kind of taking a step back and wanted to highlight, out of the Moving the Missions report, one of the most highly rated conference selections was really focused on behavioral health and its integration within CVI. And we very much recognize that this is such an emerging conversation in the field. And there's so many points of origin into how we kind of came to this point. Going back a couple of years ago here at Giffords, we started an internal project where we reached out to survivors who were actively engaged in our work to really learn about their experiences, their needs, and opportunities to support them. And one of the emergent themes that came from those conversations was the importance of having accessible, culturally affirming behavioral health services and the lack that they felt within their existing communities. As part of that conversation, I very much reflected on my own professional development and training as a licensed clinical social worker here in LA. One of the first jobs that I had was working in South Los Angeles and serving the community out there. And while I had the graduate education, I very much didn't feel prepared and didn't feel like I had the adequate school skills and training to effectively work in this space. And so what I kind of found myself doing was kind of figuring it out. And as we all know, that's not a very effective model, and it doesn't support community healing, and it's absolutely ineffective for supporting behavioral health clinicians. Right around the same time, a colleague of mine who you'll hear from shortly, Juan Carter, we were having a conversation and just kind of me asking and us exploring, from your perspective, how have you seen behavioral health be integrated in the work that you've led? And that led to a series of conversations. What unbeknownst to us was happening on the other side of the country with 2 other colleagues of ours, Dr. Bocanegra, who you'll also hear from shortly, and another colleague of ours, Kathryn Carroll, who were having a similar conversation at that time, and really looking at, well, what does behavioral health look like, and what is the role of behavioral health clinicians within this space? And so the 4 of us came together and to continue to expand upon this conversation and to ask these key and important questions to really understand, from a national perspective, what is behavioral health looking like, and how do we identify some of the best and emerging practices that are taking place across the country in a way that we can bring together and to be able to disseminate more widely. We understand that there's so much work is happening here. We spend a lot of time discussing the importance and the role of frontline CVI practitioners and how they support safety and healing in their respective communities. But we've also recognized that at a national level, we have not had much conversation related to the role of behavioral health practitioners within this space. And so, as we brought together 25 thought leaders from across the country that were representing diverse voices from frontline practitioners, behavioral health clinicians, researchers, policy leaders, we really came together last June and the third day convening after our main conference to really kind of focus on this question of what are promising practices that support the integration of behavioral health services to complement, the key is complement, the critical work of frontline workers. And today, we'll have an opportunity to not only provide some insight into some of the findings from that conversation, but to continue to build upon that and really push this work forward with our respective panelists here today. And so, just a reminder, as we start to transition into the next phase of our time together, as questions come up, if you hear something that resonates for you, you want greater detail on that, please feel free to add it to the chat. And we look forward to engaging in this dialogue with you. So what I'm going to go ahead and do is invite our panelists to come on camera. And what we're going to do is we're going to have an opportunity to hear from all of them. And so I will start with our first question, and this will actually be addressed to all of you. So all three of you were part of the inaugural convening. I have a three-part question for you. First, can you share a little bit about your background? Second, what was it about this moment in the field when I reached out to you that made you say yes to this conversation? And finally, why does it feel so important that we're having this conversation now? And so why don't we start with you, Juan, and then we can work our way down the line where you're from Dr. Bocanegra and Dr. Sharpe.
Thank you, Chris, and good afternoon to everyone. And thank you for being here with us today to have this very, very important conversation. As Chris said, I'm Juan Carter. I am the outreach manager at Giffords Center for Violence Intervention. I've been with the organization now 4 years, but I bring 17 years of experience to the work we now call community violence intervention. Work that for me started at the Nonviolence Institute in Providence, Rhode Island in 2009, where I started out as a street worker and was fortunate enough to work my way up to a director position where I oversaw the street outreach program. And over those years, I've learned a lot about strategy, about systems, about partnerships, but more than anything, I've learned that this work is deeply personal. And to answer that question, Chris, I wanted to share some moments throughout my career and my journey here that kind of will hopefully give some insight as to why I feel like this conversation is important. The first is about a young man named Devin Burney. I watched Devin grow up since he was an infant. His family is my family. His mother is like a big sister to me. His uncle, who was unfortunately killed in 2003, was my best friend, and his grandmother was like an aunt to me. So when Devin was unfortunately shot and killed in 2017, it was just another incident that hit home for me in a way that was kind of hard to put into words. I responded to the hospital that night, and I remember standing there in the middle of all of what was going on and the chaos, just standing there in grief, and something shifted for me. That was the moment when I realized this work can take something out of you if you're not careful, and it was heavy in a different way. Then just a few weeks later, another young man was shot and killed, whom I grew up with. We was neighbors. We lived on the same street. I then responded to that incident as well. But this time it was a little different for me. I couldn't even make it inside the emergency room. As soon as I got out the car, I sat on the curb and I was frozen, completely stuck, and I couldn't move. And that moment right there, it told me something I couldn't ignore. That even those of us doing the work were carrying something too. But if we fast forward later in my time at the Nonviolence Institute, towards my end of my tenure there, I was serving as a senior nonviolence facilitator, and I helped co-lead a program called SEED, which is still operating at the Nonviolence Institute. And that program had those of the highest risk. I do have to give a shout out to Christine King. I know she's on the call today. I just see her name in the chat, and um, she was there to help us with the clinical piece of the work that we were doing at the Nonviolence Institute. But we got into the final segment of that training where we talk about forgiveness. And I'll never forget two young men asked a simple question: how do I forgive? They wasn't being sarcastic. It wasn't a rhetoric. It wasn't for rhetoric. They were really asking how. And in that moment, everything connected for me. And if we don't address that, if we don't create spaces for healing, then we're asking people to change behavior without tending to the wounds driving that behavior. So I say, even in the work and in doing all the work on the ground, we can do all the conflict mediation. We can do all the relocating. We can do all the job training. But if we don't really address the trauma that not only our frontline professionals are going through, but the trauma of the young men and women that we are serving at the highest risk, it will keep spinning our wheels. And so just that question that they asked, and Christine being a part of all of those trainings, that's what brought me to this conversation, that we have to go deeper. And I believe behavioral health is essential to this work, and it's a must-have. And I think it needs to work simultaneously with violence intervention work, because we really want to reduce violence in a real, sustainable way. Then we got to make sure we're addressing the reasons why our young people are engaged in gun violence.
A tough act to follow, but Juan, that was really beautiful what you shared. And my response to your question, Chris, is actually very similar to the way that you introduce yourself. That my pathway to this work really mirrors what the convening represents, because I began in community mental health as well, just like you, and then moved into community violence intervention work. And like you, Juan, the first weekend that I took a job as a director of a child and adolescent community mental health clinic, there was a 14-year-old who was killed in the front steps of our clinic. And then the family showed up on Monday. And I'm wondering, how do I manage the traumatic bereavement and grief that the family was experiencing? And then that repeated itself over and over again. And so, coming from community mental health and community violence intervention, I've observed both fields evolve, often separately, sometimes in tension, but in the general direction towards a recognition of each other. Early in my career, I think that mental health providers were really hesitant to engage the populations or the people who work in community violence intervention. When that bereaved family showed up who had just lost their 14-year-old son to community violence, the psychiatrist who worked on our staff asked me, I need you to tell me every time this family's going to show up, if they're bringing any adolescent siblings with them. And I think that the police should be notified, and maybe we should look into metal detectors. So it was all about risk management and a general stigma placed on the families that had been impacted by firearm violence, that they were somehow a threat to the safety of this healing resource for the community, our clinic. When I later transitioned to community violence intervention work, I noticed that trauma really wasn't part of our vocabulary yet. Naming trauma was seen as soft or even irrelevant to the urgency of stopping violence. And when I made that transition, in 2009 and 2010. And I think about the very first outreach team that I was responsible for. One ended up in federal prison, another in state, another caught a domestic violence case, and the fourth is facing terminal cancer. And so those are all outcomes we know that are associated with traumatic stress that were going unrecognized. And we were expecting them to carry those burdens that Juan mentioned without being scathed by the continual exposure to violence. And so when I made that transition between these two areas of work, behavioral health and community violence intervention, I saw an opportunity to build bridges. When there was a homicide in the community, I worked with local mental health providers to try and encourage them to show up at the community vigil that was being organized by our outreach team. And not only the community vigil, but the funeral home to provide continuity of care. When a staff member, an outreach worker, lost a participant, we started connecting community mental health providers to the outreach workers and encouraging that level of support. And over time, I think that these seeds started to bear fruit because in a city like Chicago, Metropolitan Peace Initiatives and the Communities Partnering for Peace have integrated behavioral health as part of their model. And I think that's incredibly meaningful. And in parallel, I think in the clinical field, there is a continued expansion of trauma responsive approaches and a growing evidence base around the best way to respond to violence and violence exposure. And I just want to give the shout out to the Giffords deserved is that I think that this is the conference that does the best job of acknowledging trauma and wellness in its juxtaposition to doing peacekeeping work. There are many wonderful national CVI gatherings, and I feel like Giffords has done such a thoughtful job of putting a stake in recognizing it, having resources available, and generating really thoughtful conversations around what it looks like to build bridges between behavioral health and peacekeeping work.
I mean, seriously? Thank you so much, Juan and Kathryn. And I just want to say I'm honored to be on this panel with you today. And I appreciate very deeply all of the work that you do. So hello, everyone. My name is Tanya Sharpe. I am the founder and director of the Center for Research and Innovation for Black Survivors of Homicide Victims, a center I established in 2019. After working side by side with survivors, for those of you who've heard me speak before, I talk about my foundation and inspiration for all of this really being my interaction with a woman who I refer to as Edna, who experienced the murder of not just one son, but two. And it changed my whole world. The story, however, that I'm going to share with you today that is central to my why is something that I haven't really shared and don't share publicly, is the fact that I am also a survivor. My cousin was murdered in 1997. And I'm sharing that and uplifting it to the space because one of the things that I noticed at his funeral were the young men and women who were standing in my aunt's living room, helpless, struggling to figure out what next. I even heard some stories of retaliation, but also the family members being sort of in their own state of grief and unable to hold the space and support them. And I saw these patterns continue time and time again throughout several different communities. And it really began to push me to think about how are we positioning ourselves? How are we training ourselves? How are we conducting research that really allows us to understand what are the best practices for holding space for family members and friends of homicide victims? What is the best way we can train practitioners to hold that space? And when I started my career, again, I say, even though I only look 25, it was a while ago. And, I remember that despite the exorbitant rates of homicide, violence, and victimization in Black communities, no one was talking about it, right? And here we are in 2026, recognizing that, on average, homicides, roughly 20,000 murders occur in the United States. And although the United States has a population of roughly 14.4% Black people, they represent more than half of the homicide victims. That's just talking about homicide victims. When you think about each victim having at least 7 to 10 family members and friends who are left struggling to figure out how to cope with such loss, and it is repeated and it is cumulative. And we recognize that that repetition doesn't allow for us to think about post traumatic stress disorder. There is no post for Black and Brown communities. We really have to, I think, position ourselves to do a better job of responding more proactively than reactively. So that's really my why. I stepped into and contributed to the conversation at Giffords. Um, Kathryn. Kathryn said you have to be part of this conversation, to be honest. But beyond Dr. Bocanegra, who, when she tells me to do something, I do it. I also thought about the work that I was doing in Baltimore with JT and Dante, who were CVI workers who we worked together to create programming for young Black men and women who were experiencing the homicide of a loved one. And watching them share with me their personal experiences, but also struggle with that journey of understanding how the cumulative trauma and death was impacting them and trusting me with that vulnerability. But in that journey with them together, it really allowed me to begin to think about not only what were they experiencing in terms of their grief and loss, but what were the structures at play that were preventing them from trusting me, trusting different organizations, trusting spaces and places. And I think it forced the conversation into a space that I am so glad we've arrived here now, where it pushes us to ask not what's wrong with you, but what happened to you. And so I'm looking forward to continuing that conversation here today.
Thank you so much. And, Dr. Sharpe, you very much look 25. And I appreciate all of your contributions here, and very much what we've heard from all of you so far is really the conversation around healing and how does that take place. It doesn't take place in isolation. It takes place through collaboration and building partnerships. But we also have to address healing, not just at the individual level, but looking at the larger structural issues at play that can interfere with healing. And so really looking forward to getting into more in that part of our conversation today. So what we're going to do is we're going to come back to you, Juan. I think one of the things that kind of came out for me in your story was this idea of trust and vulnerability for you to be able to be in such intimate spaces with people who've been impacted by trauma and violence. And so can you tell us a little bit more, as we know that trust is so foundational to this work? What has helped you build trust with the people you serve? And what do you think behavioral health providers need to do on their end to build trust with program participants and program staff?
That's a good question, Chris. We know trust is foundational. I've always said that we need credible messages and kind of in all spaces in CVI and within the ecosystem. But the one of the things for me, or one of a few things for me, was transparency, right? Being open and honest about who I am and what I'm able to do, right, for individuals. But I think it was showing up consistently, and not only showing up in those high pressure moments, or where moments where violence was taking place, but it was showing up on days, on quote unquote off days, right, where it's sunny outside and nothing is happening, right, and being there for individuals and showing that this is more than just a job for me. And that's just I think that's just very foundational in building that trust, because we know that the high risk individuals or the participants of our programs have seen fractured systems, right, and seen fractured relationships throughout their lifetime. I think what's important between our frontline professionals and behavioral health providers is that they must mirror, right, a partnership that shows trust for the individual. Um, because if we don't do that, they'll see right through it, right? I think the frontline uh, practitioner interventionist also must believe in behavioral health themselves, whether they practice it or whether they're involved, whether they're seeking out their own therapy, whether they're through their own journey or not. I think they have to see it as something that's viable and beneficial for our participants. I think on the other side, for baby health providers, and I know I'm preaching to the choir on this panel, but it's the willingness and the availability that should be off hour type things, right? It can't be a 9 to 5 service that they provide to the high risk individuals, and truly meeting those individuals where they're at. But back to the interventionist and the provider, I think they must trust each other's expertise and understand that when you put both together, powerful things and amazing things can happen for participants or for the high risk individuals in the population that we serve.
Thank you so much, Juan. And, as you were talking about it, there was a lot of things that I really like stood out to me. We talk about trauma-informed practices in this space so much, but I think you very much have embodied that in this example that you shared, where you talked about the consistency and showing up. You talk about the importance of collaboration, the importance of transparency. And so very much can see how that really helped you build trust with program participants and really help facilitate this process of healing. And also collaboration being on equal footing between frontline professionals and behavioral health specialists. And, I think this is such an important part of the conversation, because you're really introducing it and building trust at this community individual level. But we also know that trust can be fractured by structural issues at play. And so I'm going to kick it over to you, Dr. Sharpe. And one of the questions that I have is, during our convening, we spent a significant amount of time talking about the impact of racial trauma and structural violence in shaping both the needs of CVI participants and their relationships to systems of support. How should behavioral health providers be thinking about and responding to these dynamics in their practice?
Just a small question. Just before anything else, I think it's important that we just get on the same page in terms of defining structural violence, right? Because we can't afford to lose the momentum of this conversation, I think. So structural violence it's not about one person hurting another. It's about how systems, housing, inequitable housing, policing, over surveillance, healthcare, education, economic inequality are designed in ways that consistently and disproportionately harm Black and Brown communities. Period. Full stop. Um, it's it's the violence of a child growing up in a neighborhood flooded with guns, but starved by other resources. It's the violence of a mother who calls a crisis line and is met with police instead of a continuity of care. Structural violence, it's slow, it's normalized, and largely invisible to those it doesn't touch, but it is felt acutely daily in the body and in the mind and the spirit of so many CVI workers. And so it's with that understanding, that level set understanding of that framework and foundation, that we begin to understand that we have to begin and start there when we're doing our trauma work. We only need look at what happened during COVID, where somehow we were able to say, okay, there's social determinants of health that are at play here that are disproportionately affecting Black and Brown communities' susceptibility to COVID. That same framework and that same lens needs to be applied here in terms of structural violence when we think about the impact of gun violence, the disproportionate impact of gun violence and homicide violence and victimization on Black and Brown communities. So why does this matter for CVI workers specifically? CVI workers are not neutral service providers walking in from outside. They are very much inside of this thing, these structures, and trying to operate and navigate within it. Many are survivors themselves, as we've talked about in the very beginning of this talk, and many are from the very communities that they serve. They carry their own grief, their own trauma histories, their own complicated relationships with the very same systems that are inherently violent. And so the helping work itself can be traumatizing when we understand it this way, when it's not properly supported by governing bodies that understand fully structural harm and they don't create policies that support a culture of behavioral health care that both understands the chronic exposure to structural trauma as well as the chronic exposure to individual and interpersonal violence. So that is how we need to begin to think. I often tell my students, you need to think about not just the individual that you're providing counseling to, but all the threads and structures of, all the threads of connection all the threads of connection that, and that lead us to understand how they're connected to other structures. That way, we're bringing in the whole sort of conversation fully. That again positions us to ask and invite not what's wrong with you, but what happened to you. And so for me, it's really about positioning behavioral health providers to begin to ask, how do I treat, how do I understand what has the person been navigating, not just in their work, but across their entire life? And how are we then creating policies or services that look like providing affordable mental health and physical care? How are we creating policies that look like having access to affordable wages? How do we create policies that value, as Juan said, the expertise that CVI workers bring in a way that is on par with researchers, with nurse practitioners, with physicians? Because if they're being asked to work on a team, to be able to provide violence prevention and intervention services, they need to be treated as such and compensated as such. And so that's what I mean by structures. We cannot continue to create structural harm with our CVI workers and then also expect them to work within systems that are causing that harm while trying to also prevent violence. And that's very much, I think, the fundamental paradigm shift that I'm hoping when we move from this moment to a movement we're taking to begin to amplify behavioral health services.
You know, thank you so much, Dr. Sharpe, for that. And one of the things that you said that really kind of stood out to me is, and I had to write it down. He said, "It's invisible to those it doesn't touch." And I feel like that's so important because as behavioral health practitioners, as people that are serving communities, we're often called to support communities in the process of their healing. But as we engage in this work, we're often called and asked to understand, assess the situation. But if we don't truly understand all those factors that are happening, that's really contributing to why they're in front of you at that moment, we're missing a very big part of the picture and not fully addressing and supporting around healing and where that should take place. And so I think this really helps us segue into our conversation and question with Dr. Bocanegra. At our behavioral health convening, we spent a lot of time talking about this very issue in many ways of how traditional clinical tools and strategies often fail to capture the complexity of continuous transgenerational trauma experienced by CVI program participants. Given your experience, what are the most critical gaps in the existing evidence-based approaches, and what is needed to ensure that these approaches are appropriately developed, evaluated, and disseminated?
I love this question, and I love that it was prefaced first and foremost by Tanya and her, like, I mean, people take an entire semester to unpack racialized and structural violence, and she expertly landed that plane in like 1 minute. So I'm so impressed. But acknowledging the contextual factors that generate violence and lead to trauma is, I think, the most important place that we can start. And I am, again, super appreciative that the Giffords Center for Violence Intervention created a space for us to have a conversation around, like, okay, we recognize that there's a need, but what are we doing and what's working is a really, really important question, even with all the gains and the tremendous shifts that we've seen over the last 10 to 15 years. So, and I'm thankful that you've asked me this question because I brought, I was concerned about this as a practitioner. How do I take care of the outreach workers that are in my organization that I'm responsible for? And how do I do that in a way that is meaningful to them, where I feel like I failed more often than I succeeded, even with a mental health background and a clinical license, right? And I carried that question into a research capacity when I came to UIC. And Jordan placed, thank you, Jordan, for putting a link to a free website, streetsupport.org, that is intended to be a point of reflection and a conversation starter for organizations to think about how to develop trauma responsive practice. And there's a few publications that I've been thankful to collaborate with Dr. Nathan Aguilar as well, looking at trauma exposure and community violence intervention practice. But I also want to take the opportunity to like put a pin in a critical reflection point in this, what are we doing and what works in the evidence-based process that we are developing for the community violence intervention field. I am concerned in some ways that unintentionally we've pushed a narrative, and this could be my own scholarship, that people in CVI need to be fixed or properly diagnosed, and that wellness needs to be supported for organizational efficiency. This is like a narrative I see pushed a lot. And both of those things I think are problematic. And I'm saying that as somebody with a PhD and a clinical license who's contributed to this work, because the underlying assumption is that if we can just find like the right way to diagnose people or the right intervention, that we'll have a healthier workforce and better outcomes and more productivity. But like, who among, like, think of yourselves, I'm speaking to practitioners, I'm among practitioners, like, who feels inspired to engage in healing when they feel scrutinized, pathologized, or reduced to a diagnosis? Very few people, right? And I've, building on Juan's earlier point about the importance of trust, I've seen people in practice disengage, not because they don't want support, they absolutely want support, but because it's offered to them in a way that feels like it's trying to correct them rather than understand them. Going back to Tanya's question of not what's wrong with you, it's what happened to you, right? So when we come to the topic of like what works and evidence-based practices, what I've come to believe is that what makes someone a healer or a peacekeeper is not like the absence of trauma, it's the integration of it, and that all parts of you matter, not just the trauma-free parts, but the parts that were also shaped by survival, by harm, even by causing harm, even your past affiliations, because that gang or that crew or that party clique that you were a part of gave you something that was missing. And I feel like a lot of the ways in which we're thinking about professional identity or professionalization in the field or the integration of behavioral health is to slice off that, pathologize it, and stigmatize it, rather than acknowledging you're carrying all of this in a beautiful healing journey into the field in service of people who stand in the same shoes that you once stood in the communities that you love. And I always evoke this quote from a professional mentor of mine, Dr. Lenny Quintana, who said, like, when I hear someone talk about violence intervention, I can tell if they have someone in their heart who they have an actual relationship with, who's actually been impacted by gun violence, versus an intellectual or clinical curiosity about how do I fix these people, or how do I address this area of trauma. So to kind of rein myself in a little bit, in terms of the direction I think that is promising and the opportunities I feel there are to develop evidence-based practices, to integrate behavioral health, coming from a place of love, not to fix, right? I think there's an opportunity to look at what exists and to see and to critically examine whether or not that works for our participants in our community violence intervention programs and for the workforce. There's a massive romance right now with cognitive behavioral therapy, but that is like one slice of a bigger therapeutic pie, and modalities that fall squarely within the talk therapy bucket. And there's so much more out there involving somatics, involving spirituality, involving culturally responsive practice that hasn't been, I think, rigorously engaged, but there's some really cool people out there doing this work, like the National Compadres Network is doing a lot of culturally based healing. In Chicago, we're looking at how EMDR and narrative exposure therapy help advance trauma healing for community violence intervention practice. And so I'm excited about that. And I also think there's an opportunity to better engage middle management and leadership in the development of our evidence-based practices. So I always will advocate for frontline to be at the center of what we develop. So frontline, there are soldiers, they're putting their lives at risk every single day. But what I find is that if you don't have the buy-in of middle management and leadership, that they think that wellness is like a escape route from accountability. And I've been asked directly by executive directors, like, I want to support wellness, but people still have to show up for work, and they still have to carry a caseload, and they still have to show up at that shooting the next day, or somebody does. So if we're on a wellness journey, how do we balance wellness and accountability? And I think our middle management and our executive leaders have a lot of answers to that we haven't thoroughly engaged them in. So that I think they're also a key ingredient in the development of an evidence base in support of integration behavioral health.
Thank you so much, Dr. Bocanegra, for really touching on that. I think, as you're talking as well, I'm very much a learner in this space. And so learning from all of your collective wisdom for the three of you on the panel today. And, this whole idea of this critical examination for practitioners and really understanding what is our role and how in the ways historically have we been contributing to harm, and how do we deconstruct that and re-examine that role to get us to a place closer to healing. The other thing that I think you mentioned that was so important is really looking at the whole person. Sometimes we can limit people or minimize them to their traumatic experiences or experience, but not seeing the whole person and really not understanding from the context of the importance of why they made the decisions that they did, and how that really came from a place of building community and survival to really help them navigate their individual circumstances. And so very much, contributing to this conversation overall. And the final point that I want to mention is the emphasis you placed on engaging middle management and leadership, because we recognize that while people who are working on the front lines can have all these amazing ideas, if there's not institutional buy-in, we're not able to push that forward. And so including everyone in this conversation can be so important how we're pushing this work forward. So I know before we kind of get to the final wrap up here, I think uh, all of you mentioned so many things that are interacting with each other, intersecting. And I really want to invite some further conversation around this. I see you, Dr. Sharpe. It looks like you are getting ready to chime in. So I really would, I think the audience and everyone here today would love to hear from you and just some of the reactions that you're having to what's been shared.
My gosh, we could talk for more than an hour. I mean, I just because yeesh. But a couple of things that Dr. Boganegra said that I want to uplift into the conversation that I think is also important and essential when we think about what is actually informing our practice. And I want to be clear about when we talk about evidence-based practice. And I just want to be sure that we are clear that we, have lots of research that's been done. We have lots of tools of measurement, but we should be asking ourselves, to Kathryn's point, are those tools of measurement culturally responsive to our communities? And actually, what is evidence? Evidence is also listening to the voices of community members that have been disproportionately impacted by gun violence, listening to our CVI workers, and side by side, creating some of those tools of measurement that are innovative but are very culturally responsive in so many ways. So I just really want to say that because there is often pushback, right, from grant funders, from different agencies about utilizing new and innovative tools that are very much culturally responsive and very much evidence-based. The other thing I wanted to talk about was the importance of inviting organizational systems and structures in. I think when we think about that, it's one of the reasons why I developed the post-homicide training certificate program, recognizing that I could come and do a speaking engagement, I could come and do a seminar, but how do we create sustainable, long-lasting change on the research and policy and practice level? And it is providing training and technical assistance to those organizations. You can have a training, giving them the core framework and the principles that allow them to be more culturally responsive to their continuity of care. But then 6 months down the line, checking in with them and providing technical assistance to say, how are you actually doing with implementing this thing, this framework? How are you doing with understanding these sort of spheres of influence of trauma? And how can I best assist you in actually moving forward? I think that's really important if we really want to, again, push this movement forward.
Yes, thank you so much for that. And I very much want to echo what you said is that we could spend much more than an hour having this conversation. And luckily for us, this won't be the last of this conversation and opportunities to engage in this work. So what you'll find in the chat is a link for those of you that are interested in staying involved in this conversation. If something that we discussed today has resonated with you, or you would like to be involved in furthering this discussion, please take a moment to complete that interest form there. And we look forward to engaging with all of you after this webinar and then lead up to our conference this year. So on the other end of that, unfortunately, we're getting to the tail end of our time together today. And so I have one question that I would like to pose to everyone on the panel today. And Juan, we'll start with you again for this one. What is one thing you wish funders, policymakers, and organizations listening today understood about what behavioral health integration in CVI actually requires? And where would you want them to start?
Just one thing.
Just one thing.
So I would say behavioral health integration isn't a program add-on, right? Like it's not a check the box. It has to be a mindset shift. And with the understanding it takes time, trust, real resources to meet people where they are, address trauma and support healing alongside behavior change. And we can't shortcut that. I want to reiterate what Tanya said, and Chris, you brought it up as well. It's invisible to those it doesn't touch. Like, I think that needs to be said out loud. because for the people living it, this is the work is life or death. And if you don't understand that up close, it's easy to underestimate the intensity, the complexity, and the importance of integrating behavioral health into CVI. So, Kathryn brought it up as well. We have to start by investing in the people on the front lines consistently, like outreach staff, credible messengers, behavioral health providers. We have to give them the tools and the space and the authority to build real relationships, be able to respond in the moment, and normalize healing in every intervention. And I think ignoring this, nothing else will stick. I think this is, and I said it earlier, this is where sustainable change actually begins. And anything less is just us spinning our wheels.
Thank you. Thank you, Juan. Dr. Bocanegra.
I'm inspired by Juan with two more additions to what he shared. One is that I don't think Medicaid is gonna like be a boon in this space, even though I think it's great. There's several states that are piloting Medicaid reimbursed both CVI programming and behavioral health integration, which I think is excellent because clearly funding is an issue. It's one of those structural issues that impacts the field, like how Tanya said, underpaid and unpaid labor of many, many community peacekeepers. Um, but Medicaid is a certain framework through which we're going to impose a treatment regimen on somebody. And if they don't complete their healing process in the 6 sessions that have been pre-approved within the therapeutic modalities that are pre-approved, then all right, well, we'll create like a referral for you. It could be a good start, but I don't want us to think that that's like the policy silver bullet for the integration of behavioral health here. I think we need to think more expansively, both within the public and private sector, around how to fund wellness, because it should not be something that's tacked on to like somebody else's job. And I think it should be like a certain percentage of every organization's budget, just in the way that you have an admin overhead, have a wellness like component. Um, the other thing that I was going to suggest is that I would love to dive deeper in the future about like how to build that trust in community violence intervention work. Like Chris said at the beginning, um, if you come from a traditional behavioral health background, you have to like unlearn everything and then learn it again to be effective as a behavioral health specialist in CVI work. So what's that unlearning and learning process, and like really unpacking that and hearing feedback from the people who were um, serving and providing support services from, I think is really important to know if we're missing the mark or making it work.
I mean, can I just say ditto? No, that not acceptable on a webinar. Okay, sorry. Gosh, so many things. I mean, Juan landed the plane, Kathryn landed the plane. I'm really going back to the basics, right? We really have to, if we're going to really turn this ship around, right? And root ourselves in a fundamental understanding of the root causes of gun violence, because we see and we understand the consequences, but I don't necessarily know if we've rooted ourselves fully in a full understanding of the root causes of it. I really feel as though, as a community-based researcher, um, communities will always tell us what they need. We only need listen. And if we root ourselves with that understanding, history has taught us, if we um, treat individuals with a bit of dignity as human beings, and we will stop bearing this strange fruit, but have viable individuals that can not just survive a thing, but thrive. And I think that kind of understanding, that kind of framing of all of our policies, all of our research, all of our services needs to kind of have that perspective. It allows us to stop being reactive and be a bit more proactive and strategic in our planning, our deliberate planning, of providing individuals with sustenance that they need so that this violence can be preventable. And I think that mindset will really help move this movement and this mission forward.
Absolutely. Well, I want to thank all of our panelists here today. Thank you so much for your contributions to this conversation, this dialogue. We look forward to many more conversations. Thank you to all of you who've joined us today. If you would like to stay engaged in our work here at the Giffords Center for Violence Intervention, please click on our link below. We also have a newsletter that we put out as well. And we have many links to all of our speakers here today on the professional work that they've done. So please read that, review it, to not only learn more about their work, but also use it to help inform your existing practices. Thank you so much. You have a great day, and we look forward to further conversations with all of you. Thank you.